Hi, and welcome to the Ask Dr. Angela show with everyone's favorite OBGYN, Dr. Angela Jones. Have you ever been just too embarrassed or shy to ask your own doctor a question about your, private stuff? Well, you have come to the right place to get straight answers. Feel free to ask Dr. Angela anything women's health related. OBGYN, she keeps it real. Pregnancy, she knows what you're expecting. Whole body health, just ask. Dr. Angela has you covered, girl. And now here is Dr. Angela.
What's good, people? This is Dr. Angela, everyone's favorite OBGYN. That is self-proclaimed favorite OBGYN. And I would like to officially welcome you to episode 48 of the Ask Dr. Angela podcast. Hoping that this podcast finds everyone having recovered from amazing Thanksgiving. I have to tell you that I just finally this week finished eating up the last of our Thanksgiving feast. I think I shared with you that Thanksgiving is like my favorite meal, hands down, of all time. So I treated myself to a pretty kick-ass workout this morning with my wife. It was a strength day at our cross-training gym, and it was well worth it, kind of one of those hurt so good kind of workouts. I think I previously told you that I'm pretty much about the visual. I mean, the health benefits are good, but at the end of the day, for me, it comes down to looking good in the clothes. So let's jump right into today's topic, which is induction of labor. And that's actually a pretty hot topic. I've got to tell you that when I'm on call, I always seem to be inducing someone for some reason. So let's talk about induction of labor. So just what is induction of labor? Induction of labor is your physician or OBGYN causing your uterus to contract with the intent of eventually having you deliver vaginally. With regards to why we induce labor, there are many different reasons that folks undergo induction of labor. Let's start with maternal indications. Some of the maternal indications for induction of labor might be things like high blood pressure, preeclampsia, premature rupture of membranes, i.e. being full term, having your water break, and subsequently not going into labor. Other maternal issues like diabetes, kidney disease, or sometimes when folks are on any kind of anticoagulation, whether that be Lovenox, heparin, etc., will oftentimes pick a date of induction. Some fetal indications for induction of labor are going to be things like IUGR or intrauterine growth restriction, oligohydramnios or low fluid, non-reassuring antepartum testing, whether that's in the form of Dopplers that are obtained on an ultrasound, a non-stress test that's not reactive, or a non-reassuring biophysical profile. And then certainly a post-term pregnancy, not to be confused with post-date pregnancy. Post-term pregnancy is a pregnancy that's 42 weeks or more. A lot of the inductions that I feel like we do most of the time are post-date induction, i.e. you've gone beyond your due date. One of the things that most folks don't realize is that going beyond your due date isn't a huge deal. It's the post-term, again, not to be confused with the post-dating pregnancy, that is a larger issue. So again, and I feel like a lot of the inductions that are done currently are post-dates induction. In my practice, typically if you get to 41 weeks and you haven't delivered, we will pick a date to deliver you. The other cause for induction of labor is going to be psychosocial issues like a history of fast labors in the past, folks that live a great distance from the hospital, and then last but not least, and this certainly seems to be a popular indication, elective, i.e. whether it's for physician convenience or patient convenience, but no medical indication at all. So these are elective inductions. And in my practice, and actually in most practices, elective inductions should not be done prior to 39 weeks. So just how do you go about inducing labor? First of all, we need to assess what's going on with your cervix. And, a lot of times you'll hear your doctor talk about the favorability of your cervix, or the Bishop score is another way of assessing favorability of your cervix. And certainly when we induce labor, we want to give you the best opportunity to be able to deliver vaginally. And that's part of what the Bishop score assesses, the likelihood of an induction resulting in a vaginal delivery. So when we assess your cervix, we're looking at a couple of different things. We're looking at position of your cervix. Is it posterior, anterior, mid position? You're looking at the consistency of your cervix. Is it soft? Is it medium? Or is it firm to feel? You're looking at the station of the baby, i.e. its relation to your pelvis or ischial spines. And we're also looking at how effaced and how dilated your cervix is. And when I say effacement, that has to do with, again, how thinned out your cervix is. That's the 40%, 50%, 60% that oftentimes you'll hear practitioners referring to. When assigning a Bishop score, ACOG, which is the American College of OBGYN, typically states that a Bishop score of 6 or greater will result in a favorable induction or an induction that results in a spontaneous vaginal delivery. Obvious ways that we induce labor are going to be things like Pitocin induction. That's that medication that we give you through your IV that induces uterine contractions. Sometimes we will strip your membranes in the office, and that's kind of like a very aggressive cervical exam. We check your cervix, and we also strip the membranes or separate the amniotic bag from the inside of the lower uterine segment or the cervix. I do not recommend membrane stripping prior to 39 weeks gestation, and I typically also do not perform it in folks that are positive group B strep. Rupturing membranes or breaking the bag of water is also an obvious way to induce labor, and this typically is done in the hospital because you don't want to risk having something like a cord prolapse happen and not be in a hospital setting, because that's a huge emergency. In those folks whose cervixes are not deemed to be what we call favorable, a lot of times we will bring you in for what's called cervical ripening. And the purpose of cervical ripening, again, is to get your cervix to the point where, again, it is favorable so that the induction will be successful. We can perform cervical ripening by a couple of different methods. Cervidil, Cytotec, those are prostaglandin analogs that are placed vaginally and left in place for 4 to 12 hours, depending on which one of those methods you opt for. Foley bulb, cervical ripening, which is when you take a Foley bulb and place it inside the cervical os. It causes the cervix to stretch, which releases prostaglandins, and again, makes the cervix dilate, soften, and thin out. Foley bulb cervical ripening probably is the least comfortable of the cervical ripening methods. However, when that Foley bulb does fall out, typically patients are at least a good 4 centimeters dilated. One thing to keep in mind is that induction of labor certainly is not without risk. I feel like sometimes we forget that there are risks associated with an induction of labor. Let's talk about a couple of them. How about failed induction? Failed induction, which would lead to a cesarean section. Increased risk of uterine atony. When you are inducing labor and the uterus is contracting so much, it's not going to be unheard of post-delivery to have the uterus not be able to contract down on itself, and that certainly can lead to postpartum hemorrhage. Increased risk of chorioamnionitis or uterine infection is another word for that. This can sometimes be associated with really prolonged inductions. Uterine rupture is another risk of induction of labor, and you don't necessarily have to have had a previous incision on your uterus to have a uterine rupture. Uterine ruptures can occur in an unscarred uterus. The other thing to keep in mind with inductions of labor is that sometimes these things don't happen in the time frame that we want them to. I've seen induction of labors last for hours and even days at a time, and that is not an over-exaggeration. So just make sure that you are well-informed and kept in the loop with regards to what's going on in your own care. So I'm hoping that this has provided a little bit of insight into induction of labor indications, risk associated, as well as what to expect. Thank you so much for tuning into this episode of the Ask Dr. Angela podcast. I so appreciate your continued input as well as feedback. If you have a topic that you would like to have addressed, or if you have a question that you would like to submit, please visit us at www.askdrangela, that's askdrangela.com. You can click on the microphone, which is on the right-hand side of the page, and do what you do, or you can shoot me an email at angela@askdrangela.com and submit your question that way. In closing, I'd like to leave you with this. Ideas are worthless. Execution is everything. Thomas Edison once said, "The value of an idea lies in the using of it." Just food for thought. Until next time, look better, feel better, be better. Looking forward to reconnecting with you on episode 49 of the Ask Dr. Angela podcast.
Thank you for listening to the Ask Dr. Angela podcast. For more information on women's health and the show notes for this episode, please visit Dr. Angela at www.askdrangela.com. While you're there, don't forget to leave your own message for Dr. Angela. See you soon! All of the information provided and discussed in this podcast is for educational and informational purposes only and should not take the place of consulting a physician. This podcast is not intended to diagnose, treat, or cure any diseases or illnesses and does not and should not replace treatment for a medical professional. Listening to and participating in this podcast does not create a doctor-patient relationship between you and Dr. Angela Jones. If you need medical advice or assistance, you should consult a physician. Listening to and participating in this podcast is subject to the terms and conditions posted at drangela.com/terms.